Julio, for the invitation. It's always a pleasure to be here. I love Vancouver, Canada. It's just north of where I live now, the U.S. I used to live in Mexico, now I live in the U.S. And sometimes I get confused, but last October during IDSA, somebody told me something that I always remember that said, what's the definition of a Canadian? And said a Canadian is an unarmed American with health insurance. So I'll remind you that. We had a big discussion about, they took us around the world today, and we saw some great things. From Africa, we heard about this new study by NARS, basically taking what I think is a fairly bold challenge, can treating everybody infected in a community, regardless of stage, prevent transmission. And I think they showed us the data saying, we have a lot of good coverage, 74% coverage, right, according to guidelines, 31% coverage, and we want to treat everybody, yet we're not seeing a decline in incidence. Why is that? Trying to explain that, and could this potentially be something that can be done? And the study's powered to detect a 30% reduction, and I think we're all looking forward to those results, because it's kind of surprising that with such an incredible scale-up, we haven't seen data similar to the one that has been presented from Vancouver or other places. It'd be interesting to see what the community viral load in KwaZulu-Natal is, and I would have loved to see something like that come out. China is also it's a gigantic country. They tested about 5% of the population. That's about the entire population of the US, I guess. And in some provinces, they've tested 10% of the population. They're scaling ART rapidly. They got over 100,000 people on therapy. However, HIV, I think they remind us that HIV moves a lot faster than the scale up. And what do we need to do to speed up the scale up? So detection of infections, it's important. Most people are still starting late. And this big challenge, I think, that we heard about training doctors and training patients, but this whole issue about doctors still being reluctant, and as a member of the DHHA's panel of antiretroviral treatments, I tell you that that's not a phenomenon only in China. Many doctors here in the US, and if you can see how the guidelines voted on this, basically I think that we should do opt-out therapy. In other words, we should treat everybody unless there's a reason not to, as opposed to, and we should get away from this debate of, at what CD4 should we treat? I think we should treat everybody unless there's a reason not to. But I tell you, there's a lot of people, even in this country or in the US, who are not ready to do that, and many of them are clinicians and are researchers. So we also need to train our doctors. China, India now has a lot of challenges. They're very similar: low rates of testing, late diagnosis, about 300,000 people on ART, and I think we're seeing very compelling how the epidemic that started in IDUs, starting a heterosexual population, has moved into IDUs, MSM, so it's going into the more hard-to-reach and difficult-to-reach populations. We heard this idea of public-private partnership, and we haven't heard much about the private sector for any of these countries, and I think that really is an important thing to think about, because a lot of people get their care there, even in poor countries, yet they're not included into policies and to what happens. I think a big challenge is this continued use of D4T, and it sort of reminds me of this idea of should we continue doing poor therapy in poor countries? And I think the answer needs to be really no. We need to do the best therapy possible. And second-line therapy not being available, I think it's also a major challenge. People really have one shot. Vietnam is an interesting country because there's a very recent epidemic, a very young epidemic that is growing rapidly among IDUs. I think Vietnam is scaling up rapidly, but I think Vietnam needs to really look to Ukraine and say, if we don't do the right things, could we be the next Ukraine? And what do we need to do to scale up faster? The challenges are the same: low uptake of HIV testing, barriers to care, stigma. I mean, I think the barriers that we've heard are the barriers that we've heard over the last 2 decades. Stigma, access to care, linkage to care just continue to be the issues that we need to put more focus and more thought into. Peru is a country that really has been in the forefront of a lot of really interesting interventions, and the MSM epidemic there is like in most of Latin America. I love hearing, we have a stable HIV epidemic in Peru or in Mexico or in many countries where the HIV prevalence among MSMs is over 10%. It's just unacceptable. A very high incidence, and I think it's what the Peruvian government is doing of recommending testing every 3 months and offering ARTs, again, offers an opportunity to maybe control this epidemic, which is still a very concentrated epidemic. And the proposal of doing this at acute infection, I think it's quite interesting and really brings out a potential to really avert this late diagnosis and late linkage to care. I mentioned a little bit about Ukraine. I think Ukraine just strikes me as a country where they basically, I don't know, while the Soviet Union was falling, I think everybody was sleeping and thinking about the epidemic, and just the epidemic woke up this giant monster that now has taken over. You have a country who has an HIV prevalence that makes it a generalized epidemic, and while it's not South Africa, it's still one of the worst epidemics out there. A lot of drug users, and they're seeing something that I think it's pretty obvious, and we've seen from a live cohort in other places, which is that drug users have sex, and they're more likely to transmit HIV through sexual contact than they do through drug use. And I think if we think about this population as separate, drug users, heterosexuals, and we don't think that there's one individual, then our programs, our prevention programs, continue to be vertical, and they're very disjointed and not useful. The challenges of infrastructure are huge, financing, but I think the biggest challenge in the former Soviet Union countries is this moralistic approach to drug use, this idea that drug users simply are underserving members of society that need to be in prison and should not be allowed to get anything, not substitution therapy, not ART, et cetera. I think a country like Ukraine is paying the consequences, which is having now a generalized epidemic. I like the talk on the human rights perspective, because basically thinking about the cycle of human rights violations that perpetuate HIV transmission, and I really think that one other lesson from this workshop should be to really engage human rights and treatment as prevention. Don't forget about the human rights perspective. And the fact that many people that we see falling off the cascade do so because of human rights violations. I can think about my patients in my population. The main reason why my patients stop taking antiretroviral therapy and fall out of care is because they end up in prison, they end up in jail. And this circling in and out of jail, it produces treatment interruptions and produces then losses of linkage to care, et cetera, et cetera. And most of those people are going to jail primarily for things that they shouldn't be going to jail. There's basically their imprisonment is a human rights violation. So thinking about fighting AIDS and not people with AIDS is something that we really need to emphasize. And I'll end up by I think that the lesson to me out of this session was that there are different epidemics, but many common problems. The fact that stigma is a major issue, and HIV spreads a lot faster than programs and policies. And political will to support prevention continues to be weak overall. And I do echo what Ann said. We got to take the gloves off. We need to stop being complacent. And last time I heard that was Sarah Palin. And while I don't admire Sarah Palin, I'll confess that, and I don't believe in the Tea Party, I do think that the Tea Party offers us a lesson. We need to be the Tea Party of HIV prevention. We need to stop conventional wisdom, and we need to challenge what has been done up to now, because if we continue doing what we've done up to now, we're not going to get anywhere. Thank you very much.
Okay.